All right, let's get right into it. Welcome to this explainer. Today, we're tackling one of the absolute highest stakes presentations you're going to encounter on a clinical shift, the acute scrotum. We're going to master point-of-care ultrasound, or POCUS, for acute scrotal emergencies. Look, if you've ever felt that sinking feeling of uncertainty when a patient presents with acute testicular pain, well, you're in the right place. We're going to build a rock-solid, visually driven diagnostic framework together.
Now, the reason we're here is perfectly illustrated by the stark reality of these numbers. In cases of testicular torsion, time is literally tissue. I mean, just look at this drop-off. If you can diagnose and intervene in under 6 hours, you're looking at a fantastic 97% salvage rate. But let that clock tick to between 13 and 18 hours, you're dropping all the way down to 61%. And if you go past 48 hours, it's a grim 7%. So yeah, you absolutely do not have the luxury of waiting around.
To get you moving fast against that ticking clock, here's our roadmap for today. We'll cover introduction and clinical prep, essential scrotal anatomy, the step-by-step protocol, recognizing normal variants, and finally, diagnosing critical pathologies.
Okay, Section 1, Introduction and Clinical Prep. Let's get our minds and our machines ready to go.
So, here's the crucial dilemma. Classic physical exams simply lack the sensitivity to safely rule out a catastrophe like testicular torsion. You just can't rely on touch alone when tissue is actively dying. POCUS, on the other hand, is your definitive, reliable, and super practical screening tool right there at the bedside. It takes the guesswork entirely out of the equation.
But to get those reliable answers, you've got to set your ultrasound machine up correctly. First, get your patient supine in a frog leg position with some towel support and grab your linear probe. Now, because we are looking for incredibly slow blood flow in the testicles, you need to deliberately tweak your settings to maximize flow visibility while cutting down on artifact. So drop your wall filter below 100 kHz, lower your pulse repetition frequency, your PRF, down to 1 to 2 Hz, and crank your gain output way up, right around 70 to 90%.
Moving right along to Section 2, essential scrotal anatomy, because before we can hunt for the abnormal, we absolutely must know the normal.
The prime suspect behind our most critical emergency is the bell clapper deformity. Usually, the tunica vaginalis, which is a membranous tissue layer, attaches right to the postural lateral aspect of the testicle. But in the bell clapper deformity, you get this abnormal attachment that completely encircles the testicle, the epididymis, and the spermatic cord. This basically leaves the testicle swinging freely, literally like a clapper inside a bell. And as you can imagine, this vastly increases the risk of it twisting into full-blown torsion.
Diving just a bit deeper beneath that, we have the tunica abugina. That's the tough, fibrous capsule that maintains the testicle shape and protects the inner parenchyma. Then you've got the epididymis. Remember, flow goes from the head, which sits superiorly and is usually the easiest part to scan, straight down to the tail. Finally, sitting superior to the testicle is the spermatic cord. This is crucial because it houses the vital testicular artery and the pampiniform venous plexus.
All right, Section 3, the step-by-step protocol. Systematic scanning is exactly how you avoid disastrous misses.
Listen, if you remember only one rule from this entire explainer, please make it this one. Always begin the examination with the unaffected testicle in order to set a baseline. You absolutely must dial in your machine settings and understand exactly what normal looks like for your specific patient before you even think about touching the painful side.
For this, you're going to utilize 3 basic views: the long axis, keeping your probe indicator up, the short axis, with the indicator pointing to the right, and then my absolute favorite, the buddy view. For this one, you just place the probe at the inferior portion of the scrotum, indicator to the right, and you get both testicles side by side right on the screen. It is a brilliant way to highlight direct, side-by-side comparative differences in echogenicity and blood flow.
So here is your complete 8-step protocol. Steps 1 through 6 are done on the healthy testicle first. We use B mode in the long and short axis to assess the parenchyma. Then we throw on color and pulse wave Doppler. And hey, this is absolutely vital. Use that pulse wave Doppler to confirm both arterial and venous flow in multiple regions. Why? Because checking both is how you ensure you don't miss a sneaky partial torsion or a segmental infarction. So check the epididymis, check the spermatic cord, then repeat all of that on the affected side and finish strong with your side-by-side buddy view.
Okay, Section 4, recognizing normal variants. Let's make sure we know what harmless anomalies look like so we aren't accidentally sending a patient to the OR for absolutely no reason.
When you're scanning, you might come across small, bright dots.
That's testicular microlithiasis. Or maybe you'll see scrotal pearls. Those are just extra testicular calcifications, usually from some past inflammation. You might even spot an epidermoid cyst, which has this very distinct avascular onion ring appearance. Though, yeah, probably a lot less appetizing than actual onion rings. Or maybe striated testes, where you see multiple hypoechoic bands. Look, these are normal variants or incidental findings. Note them, for sure, but don't panic.
Finally, Section 5, Diagnosing Critical Pathologies. This is what we are really on the hunt for.
And we are back to the big one, testicular torsion. It's crucial to understand the exact sequence of ischemia here. First, the spermatic cord twists. The thin-walled veins get compressed first, which causes venous obstruction. As the pressure builds up, the thicker-walled arteries then get compressed, leading to arterial obstruction, thrombosis, and eventually full-blown necrosis. Because that venous flow is compromised first, confirming venous flow is literally a mandatory step to effectively rule out an early torsion.
Now, if you strongly suspect torsion and you need to act fast, utilize this rapid two-step rule-in protocol right before attempting any manual detorsion. Step 1. Scan the testicle, checking qualitative color flow, and confirm arterial and venous flow using your pulse wave Doppler. Step 2. Follow that spermatic cord up to check for the dreaded whirlpool sign, which honestly is exactly what it sounds like, the literal visualization of the twisted cord itself.
Check out the night and day contrast on color Doppler between torsion and our most common cause of adult testicular pain, epididymitis and orchitis. Epididymitis is going to present with an enlarged epididymitis and massively increased diffuse blood flow, that's hyperemia, along with a decreased resistive index. Torsion, on the other hand, presents with absent or heavily diminished blood flow, and that telltale whirlpool sign up in the cord.
You also really have to differentiate a full torsion from a torsion of the appendix testis. The appendix is this tiny remnant structure that can twist and cause some pretty severe pain, but, and this is key, it leaves the primary testicle's blood flow perfectly intact. So it hurts, but it's non-emergent. You might also spot a reactive hydrocele alongside it. That's just fluid collecting between the parietal and visceral layers of the tunica vaginalis. Simple hydroceles are totally black and anechoic, while complex ones will have some visible debris floating around.
Now, what if the patient comes in after some blunt force trauma? Here, you are primarily looking at the integrity of that fibrous capsule, the tunica albuginea. If it's disrupted and the testicle has a weird abnormal shape, that is a rupture, which is an absolute surgical emergency. You might also see a fracture presenting as a dark, hypoechoic band running straight through the tissue. And definitely keep an eye out for a hematose cell. Unlike the clear fluid of a simple hydrocele, acute bleeding from trauma will show up as highly echogenic fluid surrounding the testicle.
Wrapping up our pathology section, let's talk about varicoceles. This is the abnormal dilation of the pampaniform venous plexus to greater than 2 millimeters, and you'll typically see it increase in size if you ask the patient to bear down or perform a Valsalva maneuver. Now, they usually happen on the left side. If you see a varicocele on the right side, if it's non-compressible, or if it's a brand new onset in a patient over 40, those are massive red flags. That should immediately make you suspect an underlying mass or cancer causing external venous compression.
And just like that, we're at the end of our explainer. We've covered the essential anatomy, the specific machine tweaks, our fail-proof 8-step protocol, and the critical pathologies. But as we all know, knowledge is really only as good as its application. So I'm going to leave you with this clinical challenge. Knowing the ticking clock of testicular salvage and knowing that your diagnostic window is literally closing minute by minute, how will you integrate the baseline buddy view into your routine on your very next acute clinical shift? Think about it, visualize it, and be ready to save tissue. Thanks so much for learning with me today.